Welcome back to Walking the Talk for Dementia, where over 4 days Atlantic Fellows joined people living with dementia, practitioners, researchers, and caregivers along the Camino in Spain to exchange ideas and to find new ways to support each other and create change.
Laurie, who's on the walk with us, brought a stone from America, and on that stone are the names of people with dementia. Thank God I'm one of the ones that's still living. But I just signed a name that I used to have when I was a DJ. I was known as Big K, and it's the first time I've signed that name. My name is Kevin, but it's the first time I've signed that name in 6-7 years. Well, I've diagnosed in 53, so I'm 60 now. 60 this year, so it's been 7 years. So.
We are on day 3 of the Walking the Talk for Dementia. I'm Fernando AGUZZOLI-PERES, Atlantic Fellow for Equity in Brain Health. We just walked a little bit more than 11 kilometers. We are at the beautiful Convent Garden, talking to Kevin Quaid, dear friend, living with Louis Buddy. Kevin, we are tomorrow going to walk towards the cathedral, which is our final point. A few years ago, you wouldn't think that the Camino de Santiago de Compostela would be something that you would achieve. And now you're here, walking as much as you can, doing beautifully. How is it going?
It's amazing. It's exceptionally emotional because 5 years ago we had to leave our house for 5 weeks while they made every room wheelchair accessible, and they had to make a quick route from our yard to my bedroom for an ambulance because I was so ill. I was on a walking frame and I was supposed to go from there to a wheelchair. That's what the medics thought. I went from the walking frame to a walking stick, and I always wanted to do the Camino. And I thought, okay, if you're in a wheelchair, you do the Camino in a wheelchair. Then I thought to myself, no, that's not how you do the Camino, you walk. And I didn't give up on my dream. The most I have walked in the last 10 years up to yesterday was 3 kilometers in a day. And yesterday I probably did 6. This has been such a personal journey for me this week. I've met the most fantastic people I am ever going to meet. This experience will never ever leave me. And you and all the other people, the way you made me feel this week, the encouragement that you gave me, I don't care how bad my dementia ever gets. It is not possible for that to leave my brain. And that for me is gold.
I am Michelle Steele, Atlantic Fellow for Social Equity, and I come all the way from Canberra in Australia. Around about 2 or 3 months prior to the Collective Leadership for Impact convening over in Oxford in early December last year, I was at work and this guy had said, oh yeah, dementia prevalence for Indigenous Australians is 3 to 5 times higher than all other Australians. It's actually climbing as one of the highest burdens of diseases. And I'm like, so what are we doing about it? And he's like, I don't know. And I'm like, well, have you spoken to our Indigenous leaders? Have you spoken to gerontologists that specialise with Indigenous communities? All these questions that flew up for me, and none of them had any answers. So I made this play for the brain people in Oxford, and one of them happened to be Fernando. I said, you got to link me into who in your cohort are doing things about Indigenous communities throughout your programs. Who are they? Where are they? And he started talking about his personal experience with his nan, and then we made these similarities that throughout cultures, there was no traditional words for dementia or for memory loss. And in my head, I started thinking, it's right, within my own community, we use this word wamba. Wamba is funny, but it wasn't funny as in like a ha-ha comedian sense. It was wamba as in because they were starting to go a little bit different. So that for me just triggered this passion that I didn't know that I had within me, which is not only do we need to think about all those things that actually contribute towards dementia and prevalence rates within First Nations communities within Australia, but also how do we care for our elders that are actually getting this disease? My grandmother died of dementia. At that particular stage, I wasn't really quite sure what it was, but I know that my mum struggled with the care and the care options that was available. And then my dad was diagnosed at around 57 and he's transitioned now to early stage. My dad used to be a boxer And what scares me the most is if he reverts to violent behaviours and the impact that that could potentially have on my mum. And that scares me a lot. So I want to know more, not just because of what's going to happen at home and to be aware of behaviours or be aware of indicators or what can you do to relieve stress, all these things. But at the same time, he's not a child. He also needs to be in control of the things that he can do. So I was very, very fortunate. Fernando said to me, Michelle, we don't have any representation from Australia or New Zealand, but Michelle, more importantly, we don't have much representation from Indigenous perspectives. And what does that look like? And so very late to the piece had asked me to come along.
Okay, guys, so we are able to pick everybody on the photo, but you should be...
So today was the last day of walking the talk for dementia. We started with an amazing surprise for most of our group. When we arrived at Monte do Gozo, where we started, we had around 200 people waiting for us there, coming from all over Galicia, buses with people living with dementia, family members, and representatives from organizations all over the state. I just want to go back more than a year ago, where Clara and I, we didn't have any sort of idea on how to start this project, and then I got to meet Gustavo SAN MARTIN from Brazil. I mentioned to him the project, and then he told me a little bit about his story with his grandma.
Thank you, Fernando. I'm Gustavo SAN MARTIN. I'm the founder of CDD, which means Day by Day Chronic in Brazil. I've been working with rare and chronic disease since 2011, 2012, when I realized that I have MS, multiple sclerosis. At some point, I realized that living with a chronic disease is more than just our diagnosis. So I really wanted to change their perspectives of life. After receiving the diagnosis, my grandparents from my mom's side, they died with Alzheimer's disease. My grandfather lived around 2 years after his diagnosis. And my grandmother, she lived almost 9 years. And my mom used to take care of her. When Fernando told me his idea, I couldn't say no, because both my grandparents are from Galicia. And my grandmother, she helped me a lot when I realized that I had multiple sclerosis. She gave me not only a purpose, but also the chance to develop my idea about starting my own patient group and helping to change the reality of people living with multiple sclerosis. She supported me a lot. That connection of Galicia, Camino de Santiago, Alzheimer's just felt like a purpose to me. We came to Santiago de Compostela about 18 months ago. Clara is a neurologist from Santiago de Compostela. She's a fellow of GBHI, and she's a friend of Fernando. We started to talk about our dreams, and everything seemed so connected that the day after we started to do Walking the Talk for Dementia, even if we didn't know the name of the project yet. Right, Fernando?
Yeah, exactly. Clara had the local connections that we needed for making this a reality. Gustavo had experience and also funding for us to begin the project. Much of our anxiety was because we didn't know how this group of very diverse people was going to mingle and connect. And we were really, really lucky because we formed a family more than a group of people.
When you started, you said the last day of the Camino. For me, it seems the first day of the rest of our lives, living, but also doing something for dementia. It's about changing realities, it's about changing lives, facing stigmas, and also showing the world that people with a diagnosis, such as multiple sclerosis, but also dementia, they have their right to keep living, to keep doing their things, keep dreaming.
So, we'd just like to give a few words of gratitude and appreciation for what we can all agree on has been the most remarkable and transformational week of many of our lives. And we haven't done this with abstracts, and we haven't done this with scientific publications. We've done this with walking and talking and thinking and sharing and being together. So, on that note, we just want to express our huge appreciation to many, many people, of course.
My name is Brian Lawler. I'm Site Director for the Global Brain Health Institute, based at Trinity College Dublin. I'm here in Santiago de Compostela to support the Walk the Talk for Dementia. I participated in the walk this morning, really enjoyed it, rain and all. And I've got two great people here, Laurie and I've got Barry. So over to you, Laurie. Tell us a little bit about yourself.
So I'm Laurie Waters. I'm 57 now, I think, or 58, I don't know. I was diagnosed with early onset Alzheimer's at age 52. When I was first diagnosed, it was very scary being such an early age with Alzheimer's, because everybody that I saw at that time was 60, 70, 80 years old and in later stages.
That's a misconception, I think, about dementia. Everybody thinks dementia is something that happens to people who are old. In fact, we know that 1 in 10 people who get dementia are actually under the age of 65. So it's really important that people like you who are living with the condition at a young age are able to talk about it and let people know. People like me, I'm a psychiatrist by training, we learn so much from people like you. Learning is both ways, isn't it? I always feel that I learn so much from the people that work with me, the patients, the families, people telling their stories. But to see people like yourself and Barry walking the talk out there, showing that it can be done, living well with dementia, with purpose, it's quite emotional, it's quite uplifting. And for me, it's just a wonderful experience to see it.
Personally, that's what this whole entire journey has been the past 4 days, is walking beside researchers and physicians and psychiatrists and neurologists and learning from each other that we all have the same common goal.
One of the things that the Global Brain Health Institute is very much supporting is this idea that to change the narrative around dementia, we've got to break down these professional silos and work with people like yourselves. Patient public voice, this is so important. So Barry, you're from Namibia. Tell us a little bit about your experience. You're living with dementia, is that correct?
Yeah, I was diagnosed positively in 2020, November. I'm the founder and the CEO of Alzheimer's Dementia Namibia. I started off in 2009. We do have a care farm in Namibia where we care for people living with different dementias. Between 200 and 300 people we have cared for over the last 12 years. But a great deal of my work is in rural Namibia, where they perceive people living with dementia as witches and kill them, ostracize them, burn them. It's a huge stigma.
In Ireland, in the old days when people would develop dementia, they would say they were away with the fairies, which was almost like mythology and almost like witchcraft as well. So this is probably in every culture, but you're trying to change this narrative. And I guess walking the talk is showing people that people living with dementia, they're not witches.
Yeah.
They're like everybody else, they're human, and that's what's important. Tell me a little about these care farms. This is a concept that I'm not completely familiar with. Sounds interesting.
Yeah, I called it a care farm because I noticed that people with dementia, they want to walk for some reason. And then I start looking for an old farmhouse in order that they can have space where they can walk freely, where they can be in the sun, out in nature, because we as Namibians are people of nature and of big spaces. So the concept of this is your room is only where you sleep in. Even if you lose your mobility, you just sleep in your room.
It's really, really interesting because what you're doing is using the environment, nature, as a stimulant for brain health. And we know scientifically that this really does help cognition and memory when people are engaged with nature, and you're promoting physical activity as well. So this type of lifestyle is really, I'm sure, helpful to stabilize trajectories or courses for people who are living with dementia.
You're 100% correct. We're not using, for instance, medication. I'm talking about mood stabilizers, anti-anxiety medication. We use antibiotics, but not antipsychotics. Psychosis mostly is because of the urinary tract infections and stuff like that. So we're making use of the environment, nature, of exercise, being in the sun. I myself built my own room for the future in such a way that it can stimulate all my senses with big windows and sliding doors overlooking the desert.
I think we can learn an awful lot from this approach because to my mind what you're doing is reframing dementia from the perspective of brain health. Because even if you have a dementia, if you're living it, you can have brain health and you can promote your brain health. And that's what you're doing. You're modifying lifestyle, you're looking at exercise, you're engaging with nature. You've got a lot of social connection. You've got a community there.
Yes.
All of these things are so important for your brain health, even if you have dementia.
Yeah.
So I think it's a very positive story. What's happening in the United States with regard to awareness?
There's still a lot of work to do. I mean, thank goodness we've been pushing it in people with younger onset. We're letting our voices reign high and proud. We were at the White House because CMS, which is the Center for Medicare and Medicaid, didn't want to cover our medication. A new drug came out that can stop it in its tracks. And they said, no, we're not going to cover it. So we went to Washington. We protested in front of the White House. We met with congressmen, senators. And fortunately, the day before I arrived, got the news that they're going to cover us.
I think when you're in the middle of all of this, it's hard to see this, but I think we've come a long way. In 1991, there was no such thing as public patient voice. People like you were not talking about dementia. You weren't walking the talk, but you're walking and talking. And I think people are beginning to listen, and you're beginning to be heard, whether it's about rights and medication or whether it's about dementia is not witchcraft. People need to be respected as individuals, no matter what. This is an illness. I think we're in a much better place than we were, but we need more people like you to walk the talk and to show that even with a very serious illness like a dementia, that with purpose in life, there is quality. There can be happiness, there can be joy, there can be more than moments. I think that's really what's important. I think I experienced that today. I saw it and I heard it in the conversations that I had.
You are wasting your time researching Lewy body dementia unless you speak to the people who are caring for those of us who have it. The poem is called Kevin, Louis and Robin by Kevin Quaid. Kevin knew Robin. Robin didn't know Kevin. Kevin made hundreds laugh. Robin made millions laugh. Laughter and good humour hid the pain that Louis was causing again and again. Robin was in pain, but didn't know why. Kevin's pain was relentless, to the point that he would cry. Robin searched for answers, but couldn't find them. Kevin's search brought him Louis, but it didn't let it define him. Louis was the cause of the pain. Louis was the cause of the fear, while draining us of our good cheer. Louis was the reason Kevin and Robin hated the night. Louis was the reason Kevin and Robin were consumed with fright. Louis will make you think you are going mad and make you forget the good times that you've had. Louis will hide and drive you insane. Louis will cause you the world of pain. Louis is sneaky, menacing and unfair. Lewy body dementia just doesn't care. Louis took Robin without Robin knowing. Louis tries to take Kevin. Kevin's not forgoing. Many a battle is had with Louis. Some are won, some are lost. The end result is it will cost your body, your mind, and even your life, unless you fight with all your might. Lewy body dementia is a horrible disease. It must be stopped and brought to its knees. So join me in the fight. Bring it out to the light. Get rid of the stigma. Let's fight in plain sight. Thank you.
Hello, I'm Camino. I am a psychiatrist and lecturer from Durban, South Africa. I'm also an Atlantic Fellow for Equity and Brain Health. I'm in Santiago for the Walking the Talk for Dementia experience. We've done 4 days of walking and talking, and now it's 2 days of the symposium. We've had a lot of amazing conversations and fostered a lot of collaborations and connections that we will carry forward from this experience.
I am Michelle Steele, an Atlantic Fellow for Social Equity. I had the pleasure of being on a panel with Maria, who was talking about the inequities of gender in dementia. During the panel, we had an opportunity to realise that actually if we were to combine both gender and indigeneity in terms of highlighting inequities, that perhaps our voices could be a little bit stronger within this area.
My name is Maria Teresa Ferretti. I'm a neuroscientist, neuroimmunologist. I'm a researcher in the field of Alzheimer's disease. I'm the co-founder and chief scientific officer of the Women's Brain Project, a non-profit association that studies sex and gender determinants to brain and mental health as the gateway to precision medicine.
My name is Lebo Molete from Johannesburg, South Africa. I am a fellow on the health equity program in South Africa called Camino. And on this walk, I met Maria Teresa, and she's able to take very complex scientific concepts and make them accessible to a lay person. That's what I needed, and I think that's what a whole lot of people need who are tackling dementia at the ground level. So I'm excited to be here, and I'm hoping out of it will come a lot more collaborations. Apart from getting complex information and simplifying it, we have to be able to translate it again into different languages so that it's also culturally appropriate when it's delivered to communities through radio. And I'm glad again that this event has brought me in contact with Kanye. She works in the same countries I do, in a different part of on the east side. She works on radio, but with politicians directly, and she's a clinician. And I think there's a lot that we are going to share as well.
Yeah, we're active on the radio, but it's always about how sustainable projects are. It is such a powerful tool because in our culture, in our country, listening to the radio is what people do every day. Even when they are working on the field, there's radio shows where you must send a shout out to your family. And this person will be like, hi, I'm out on the field, I'm plowing, but shout out to my aunt who's up in Joburg working. So the reach is so wide. And we've seen when we do advocate on radio, because I also support dementia advocacy groups as a clinical lead, people are just like, you know, what you're describing, I didn't know there was a word for it, but I'm here struggling. And then the follow-up is, where do I go? So when you raise awareness, you're giving people information, and then you're capacitating them to say, okay, you're at home there in your village, this is where you go, these are the pathways to care, and it starts the conversation.
So this is the beauty of collaboration, right? It's not only about that direct collaboration, it's about learning and taking the insights as well. Australia also has similar access to radio stations. We have an Indigenous broadcasting service, and especially to remote Australia, and quite often it's delivered in local languages because Australia's language is so diverse. We have over 250 languages, 700 odd dialects. So that ability to actually utilise radio as a forum to get messaging out, and important messaging, especially around dementia, for example, is an idea that I can take and replicate. And Lebo, that's where your practical example around how you have utilised a local radio first and then scaling up, thinking about what does that mean nationally, is a concept that I think Australia can really grasp onto and learn from.
So for me, one really great outcome of walking the talk for dementia might be even to start collaborations with a lot of you guys. A lot of health data, dementia-related data that are collected do record if a person is a man or a woman. The point is to go there and analyze it. So I see a lot of opportunities for us because we might start a collaboration, a project where we see what data have been collected so far, and we stratify this data by sex and gender if possible, and we see if we notice the same differences that we have in other cohorts in other countries, and we start reasoning together based on the data what could be the next steps, because we need evidence to make the point, especially for policymakers. We have been studying at the Women's Brain Project both sex and gender differences in Alzheimer's disease. When I'm talking about sex, I'm referring to biological differences driven by chromosomes and hormones. Gender is the sociocultural construct of being a man or a woman in a given society. There are biological differences in the disease. Women tend to be more vulnerable to progress faster with the disease, to accumulate more of the tau pathology, and this might be linked to hormones, especially to menopause. But there are also gender differences, so the the social, cultural, and the social determinants of health. One typical example is access to education. Low education is a risk factor for dementia. Unfortunately, in many countries, women have more difficult access to education. So these type of differences are important to consider to tailor then solutions. And we have to see how these differences, studied mostly in Europe, in the States, in very well-developed countries, we actually have to go back and see how they look like in completely different geographies.
Maria's work is very interesting because it's things that are not necessarily the first thing that people think about. We know about them, but we're not really aware. But the information and all the data that she's gathering should help us in how we practice and how we research and in how we advocate. So it's a big gap that we need to be more active about trying to bridge and trying to be more active in making people aware of those things.
One of the sessions this afternoon is, what can I do next? And I want to create a First Nations specific arm of dementia within our advocacy and policy space, thinking about community awareness and radios, but really draw on the inspiration that we've picked up here to commit, to take that home and make that difference.
Hello, my name is Angga Dwi Marta. I'm one of the Atlantic Fellows on Health Equity in Southeast Asia. We are here on the final day of the Walking the Talk for Dementia. We've been hearing a lot of new ideas from the symposium, and we are in the coffee break. I realized from a lot of talks that on the issue of dementia, young people have a lot of power to contribute on the research, to contribute on the advocacy, and I could see three main roles of young people. First is young people as beneficiaries. A lot of stories about young people being caretakers, the grandson or grandchildren of people with dementia. There's also young people as collaborators. And I think there's also young people as leaders.
My name is Maureen Sagauke. I'm from the Atlantic Fellowship on Social and Economic Equity. Zimbabwean by birth, resident in Zimbabwe. I'm a young leader working with communities. So when you start talking about young leaders, I think of exactly the same things that you're looking at. Young leaders as agents of change, young leaders as caregivers. Because where I come from, when you start talking about care for the elderly, the people who find themselves caring for the elderly are what we define as young in my context, which runs up to 35 or up to 44. But most importantly, I think young leaders as myth busters. Where I come from, we believe that dementia, and this has been an aha moment for me in this Camino, I thought dementia was a natural aging disease. I thought dementia was white as well from a racial perspective. Therefore, it was a global north phenomena. And when I started talking to, for instance, Randall, telling me his work with young people in the clinic, it was like a light bulb moment to discover that it's not what I thought it was. And it could affect people of different ages, including young people.
My name is Randall Perez, and I am the director of the Young Onset Dementia Clinic, which is a national plan in Costa Rica to attend patients who have a young onset dementia. The most important thing is to make the diagnosis of dementia a multidisciplinary diagnosis, not just a diagnosis for the clinician, not just a diagnosis for a neurologist, but a diagnosis that goes with the hand of the caregivers, of the nurses, of the psychologists, of the policymakers, of the people who really can make changes in this world to attend the people with dementia, especially in the young ones. The whole population that is affected by dementia suffers from inequality, but the people that have dementia that start before the 65 years suffer more inequality because they have generally bad diagnosis, they have difficulties approaching medical doctors, and when they can approach medical doctors, sometimes the approach is incorrect. For example, some of these patients are just taken as psychiatric illnesses, as depression or anxiety, while as a matter of fact they are developing an atypical course of an Alzheimer's disease, which these young onset dementias have by the norm.
As you were talking, I tracked back to the conversation we ended up having and the presentation you just gave about how government and decision makers at a policy level can change the trajectory of how people interact, deal, and manage dementia. Because I'm from a fellowship that focused on socioeconomic inequalities. Where do we locate the role of governments when you're looking at making sure that people interact with dementia better? And the case of Costa Rica gives me hope. The fact that there was a deliberate willingness to focus on health and education, and that has seen multiple trickle-down effects in terms of addressing mental health and health in general. What do you think, Anga?
Yeah, I also agree. And I think what you're sharing today is, yes, you're helping people with dementia. You work for and with them. But at the same point, you also try to bridge the connection with the government policy-making process and the data and evidence that you have from other research and from the health perspective itself. I think it's truly bring back the perspective that health is everybody's business.
I told you yesterday that we have a huge skills gap insofar as experts who might be able to deconstruct, demystify brain health and different associated conditions. So where I'm standing, I wouldn't be able to do my work if I don't interact with a technical person. So I'm seeing collaboration here with technical people, but most importantly, technical people who have a positive story to tell, coming from similar context where I come from. So I'm definitely seeing linkages. Are you, Anga?
That's totally true. And I also feel that the Atlantic Institute, we have a lot of fellows that have a lot of skills, not on brain health like me, but we have a lot of skills on community organizing, youth engagement, running a campaign on social good. And I think that's skills that we can bring also to the table. And I really appreciate this connectiveness of different background and different expertise, because it needs a village to move the issue, no? It needs everyone to take their own parts.
I think this is one of the most important experiences I had in my whole life. So I hope to collaborate with this beautiful process of creating a network.
I am Camino. I am a psychiatrist from Durban, South Africa. Today is the last day of walking the talk for dementia.
I'm David Young from the Netherlands. I'm an innovator in elder care with tech.
My name is Melissa Chan from Singapore. I'm a service designer and Atlantic Fellow for Equity in Brain Health.
My name is Temitope Farumbi from Nigeria. I'm a neurologist and founder of Brain Health Initiative Nigeria.
So David, can you tell us a bit more about what work you do? We've seen you with your interesting gadgets.
So what we have here on the table is a virtual reality headset, something you can put on your head and then have a virtual reality experience. I always compare it with putting on diving glasses. You put your head under the water and you can see all the fish. We try to make impact in the lives of caregivers to, for example, show them how it is to have dementia. What we also do is train nurses, for example, how to deal with complicated behavior of somebody with dementia, but also how to give feedback. And for people with dementia, what we do is to make videos of places they went to when they were younger, where they could go when they were younger, and now they can't anymore.
I'm just wondering, when you test these solutions with the users or with the people living with dementia or their carers, bringing the sensory experiences to them, what were some of the most memorable reactions that you got from them? Were they afraid at first? Did they look excited after taking off the VR headset?
What we see is there's always some people that are a little frightened to put a headset on, because you put a headset on, you don't know what's going around you. That's why the audio is also important. If we put a headset on, ideally we also put a headphone on. But the most beautiful thing I experienced was that there was an elderly lady who expressed that her last wish was to go to Africa, to the savannah. And one of my interns, we had a headset, and he went to the facility and he gave her this experience of being in Africa. After the experience he got of being in Africa, she really calmed down, and she was really anxious before because she was terminally ill. And then that evening she passed away really peacefully, the nurses told us afterwards.
One of the major problems we have in Africa is access to health care. And myself and my team were trying to create a telemedicine platform, because we know that there are so many logistics visiting the hospital and the caregivers, family caregivers, and the burden on them. There's not enough time to bring them to the hospital. But with the telemedicine platform we created, Health app, you can do a virtual consultation with them in their home. And I can see where technology is interfacing with healthcare service and delivery by bringing it closer to the people. It improves the efficiency of our services. And I think for us in Africa, where a lot of our patients, especially the elderly one, lives in the rural community, to be able to bring the city to them, we go a long way to bridge that care access gap.
I think it's so amazing to see how technology is used in different continents. In Singapore, we have developed this solution called CARA. CARA stands for Community Assurance, Rewards and Acceptance. It's a solution by Dementia Singapore. It's a community-based organization. It's on ground, and the whole idea is to support the safe return of people living with dementia. So in Singapore, with the CARA solutions, with the safe return function, members of public can connect with family carers through a unique QR code to then initiate that contact and support the safe return of people living with dementia.
And you can bring it anywhere because software is not bound by borders. So your app could be implemented in Africa. My apps and software can be downloaded in Singapore.
Yeah.
Your app can be also used in rural areas.
It's just software for everybody. Touch is still very important. And the family caregiver can actually be the hands of the physician in expressing touch.
It's a resource that we can use in so many places, that we can use for training. We can decrease caregiver burden because we can train caregivers. We can help with respite. So I think the beauty of this technology and being able to use it in so many facets really helps with what we're all trying to achieve. And like what you guys are saying, it can bridge borders and be accessible to a lot of people.
I would like to invite someone really special to our group, someone that since the beginning was enthusiastic for this event. Unfortunately, couldn't join for the walk, but he's here, Alexandre Kalashi. I could call him doctor, professor, but fortunately he is our friend as well, as you are all. So Alexandre Kalashi would like to say a few words, which is an honor for us. So thank you so much for coming and for agreeing on having our closer remarks.
Thank you so much, Fernando. I know that's a great
My name is Urasima Leroy. I'm a professor of geriatric psychiatry with the Global Brain Health Institute at Trinity College Dublin. I'm participating in an incredible event called Walk the Talk for Dementia in Santiago. With me is Professor Kalachi, former Director of Aging at the WHO, and I wanted to ask him to share his ideas about this event.
I have been working for 48 years on aging. It's a long time. I have seen many events, many initiatives. This one is unique in the sense that you are bringing the people with experience. It's not an academic research that you interview and you have p-values and numbers and percentages. It is with emotion. And it is only with emotion that you can change things. Yes, we need evidence. We need hard science. I am an epidemiologist. I know how to measure things, but I don't know how to measure emotions. I don't know what makes things change. The Camino de Santiago. There is a saying in Portuguese, which is my home language, that says that the Camino, the pathway, we can only do by walking. And we are here walking in order to bring with passion the change that is needed to turn this page of stigma, not only in relation to Alzheimer or to dementia, it's about mental health issues altogether, combined with something very powerful, the last taboo, ageism.
But there's something else that's here as well, I believe. Something that Augustine Ibanez of the Global Brain Health Institute said yesterday. Science happens here. What do you think about that?
I think that Augustine is right, because we are incredibly arrogant, we, the so-called scientists. We dismiss what is done with passion. We only think that numbers will matter. We do need them, because when you reach the policymakers, you need the evidence to show, look, this is happening. But also behind that, you need to come with the colors, with the flame, with the fire that will ignite the real change that is needed.
You've been listening to Walking the Talk for Dementia along the Camino in Spain. If you want to learn more about Atlantic Fellows and their work for equity, please go to our website at www.atlanticfellows.org. I'm Fionnuala Sweeney. Thank you for listening.